Thank you very much for the kind invitation to give this lecture on the Neuro Lily Conference 2021. My name is Mathieu van Jagt. I am a neurointensivist working in the Erasmus Medical Center in Rotterdam, the Netherlands. And I want to discuss with you blood pressure management in subarachnoid hemorrhage and when to induce arterial hypertension. So I want to discuss some issues with you regarding induced hypertension in subarachnoid hemorrhage. First of all, the pathophysiology, or why do we think we need to induce hypertension? What do the guidelines say? Are there any updates in the evidence and the practical implications? So first about the pathophysiology. As you know, in a normal physiological state, there is an autoregulation curve, meaning that within a mean arterial pressure between 70 and 160, there is a stable cerebral blood flow because the arteries of the brain can adapt, they can dilate and constrict depending on a higher or lower blood pressure. Eventually, when blood pressure becomes too low, then the reserve capacity is exhausted and the cerebral blood flow will diminish and be insufficient. And on the other hand, when blood pressure becomes too high, then you will have a hyperperfusion syndrome, which can lead to brain edema. However, when there's a subarachnoid hemorrhage, the autoregulation curve shifts. So in the green, you see the normal area where, depending on mean arterial pressure, cerebral perfusion pressure is adequate. But in pathologic states, such as mild or severe subarachnoid hemorrhage, you see that the autoregulation curve is shifted and the cerebral perfusion pressure and thus the blood pressure should be increased. And this is the rationale why blood pressure can be increased or should be increased, according to most of us, in states of disturbed autoregulation. And this is actually the basic idea behind the benefit of induced hypertension. So to go a little bit further in a study I discussed before in my previous talk, this is the study by Elke Mwench and others, and they tried to differentiate the effects of induced hypertension from volume loading or hypervolemia hemodilution therapy. So they did sequential intervention in 10 SAH patients and in a healthy porcine model. So the pigs did not have a subarachnoid hemorrhage, and they did measurements within subjects. So also in these 10 patients, baseline measures of cerebral blood flow and cerebral oxygenation after induction of hyperthermia. Then back to baseline, then they did volume expansion or hypervolemia hemodilution, and then they combined the volume expansion and the hypertension. So it's important to say that the pigs were healthy with intact autoregulation and all patients with subarachnoid hemorrhage had disturbed autoregulation. So the pigs did not have any effect of any intervention on ICP, regional cerebral blood flow, or cerebral oxygenation, meaning that with an intact autoregulation, nothing happens when you do these interventions. So the hypertension or the volume expansion or the combination. However, this was different in the patients. So as you see over here, when you only, when they only induced hypertension, the cerebral blood flow improved, as well as did the cerebral oxygenation. And they did this on several days, day 1, day 3, day 7. When they gave only volume loading, then nothing happened to cerebral blood flow, but the cerebral oxygenation decreased, so it got worse. And then when you combined the cerebral blood flow improved. So that's the combination of volume loading and hypertension, but nothing happened to the cerebral oxygenation, and it did not improve. When you look at the intrathoracic blood volume, which is a measure of the volume of blood within the thorax, or actually a measure of preload, then you saw that with hypertension, it went up, and with volume loading, not so much, probably because of the venous capacitance. So the venous blood vessels, the veins, they can dilate, and when you give volume, nothing happens to the blood volume because it goes away in the venous capacitance beds. And when you combine with hypertension, then this number went up again. And as I also showed in my previous talk, with volume loading and hypertension, the cerebral or the CVP went up very significantly, up to 20 or 25 millimeters of mercury. So there was a true increase in venous congestion, you might say. So this study shows that induced hypertension leads to better cerebral blood flow and better cerebral oxygenation. Volume expansion alone gives better cerebral blood flow, but a decrease in cerebral oxygenation. And the combination, so the classic SAH, gives the best increase in cerebral blood flow, but it does not really improve the cerebral oxygenation. And you should really mind the venous effect. So there's, I think, there's really a signal of venous congestion because of the strong increase of central venous pressure with SAH therapy. So how can we understand this from a physiological point of view? So I have tried to explain this with these pictures. So this is the normal situation where you have the arterial bed, the capillary bed of the organ, in this case the brain, the venous outflow, then you have the venous capacitance vessels with the stressed volume, which is actually determining the preload and the right atrial pressure of the blood going back to the pump, which is the heart, and the unstressed volume, and this means the blood volume not contributing to the preload of the heart. So when you would add a vasopressor, what happens is that the venous capacitance vessel, they constrict, and the stress volume will go up, and there will be more preload, and the cardiac output goes up, and cerebral blood flow can also go up because of the increased cardiac output. What also happens, you see this on the left side, is that the arterial bed constricts and mean arterial pressure, see it over here, goes up. So you get hypertension. And that might actually improve, especially in case of disturbed autoregulation, the cerebral oxygenation. So back to the normal situation. Then what happens when we apply volume loading, fluid loading? Then what happens is that the stress volume goes up and the preload goes up too. It might have a variable effect on the PbRO2. This is because, as you see, it turns lighter because the hematocrit will dilute. So your oxygen carrying capacity goes down because your hemoglobin level goes down. So it may not really improve oxygenation. It might or it might not. And you see over here that, of course, the arterial bed will also be better filled up with volume, and then cerebral blood flow can go up. So then what happens in the case of true fluid overload? That means that the stress volume goes up significantly, and then you have actually a venous outflow obstruction because the CVP contributes to that. So you might have worse oxygenation and your cerebral blood flow may go down. So in this case, as you can imagine that you should give diuretics because of the venous fluid overload, and you should not give norepinephrine because it may increase blood pressure on the arterial side, but it may also increase central venous pressure and outflow obstruction out of the brain. So this is the pathophysiology, but then we have a systematic review from Dutch colleagues showing that from the few studies that were present at that time, this was 2010, there was no good evidence for a positive effect of triple H or its components, but the most hopeful was in fact induced hypertension, which was also justification to do the induced hypertension trial, which I will discuss in a moment. On the other hand, we should not think too easy about the hypertension as an intervention. So this is from a review I published in 2016. Over here you see in systemic circulation you can add fluid, and it can have a certain tonicity and a certain volume, but then there are all kinds of intermediate factors that influence the relation of the fluids with the effect on the brain. So you can have an improvement of cerebral blood flow and oxygenation, but you can also increase cerebral edema by giving especially too much fluids. And this relation between fluid management and hemodynamic management and the brain are these factors, among others. So the CSF, inflammatory response, autoregulation, venous impedance, systemic circulation, which is determined by vascular tone and permeability, and also by cardiac function, and of course the blood-brain barrier. And all these factors should be viewed in collaboration. And there are many, this is not to discuss it in length or in depth, but this is just to show, when you look at the yellow, these are all possibilities to intervene in this system of hemodynamic management, which may influence the brain, both in a good sense, but also in a harmful way. And you see, we will now discuss the norepinephrine and also a little bit about autoregulation. So what do the guidelines say about induced hypertension and SAH, and is there new evidence? So just a little bit about blood pressure itself. So there's no guideline from 2013, the European Stroke Organization guidelines. And there it was stated that you should not treat hypertension unless it is extreme. And extreme hypertension may be regarded as a blood pressure systolic of above 180 in case of a unsecured ruptured aneurysm. On the other hand, blood pressure should always be kept, a mean arterial pressure above 90 millimeters of mercury, which was a good clinical practice statement. So there's no firm evidence for this, but it was an advice all the same. And in the American Heart Association guidelines for the management of aneurysmal suprarenal hemorrhage, they stated that there were no randomized trials up till quite recently, and worsening of, or they see proof in efficacy of induced hypertension. They think it's convincing because a patient can really respond when you increase blood pressure. Actually, I doubt it, and I will explain to you why I kind of doubt this certainty about the efficacy of induced hypertension. And another statement is that you should really try to induce hypertension and euvolemia. So then from the critical care recommendations from Neurocritical Care Society Multidisciplinary Consensus Conference 2011, it was stated regarding blood pressure that patients with DCI should undergo a trial of induced hypertension, and blood pressure augmentation should progress in a stepwise fashion, taking into account the neurological response of the patient. And finally, about inotropes. So these are cardiac supporting drugs, which is something else than compared with vasopressors, which only constrict the blood vessels and increase blood pressure. So this is dobutamine or milrinone, which are most used. So if a patient with DCI does not improve with blood pressure augmentation, a trial of inotropic therapy may be considered. But you should mind, of course, the beta-2 agonist properties, which may lower blood pressure. I would anyhow suggest to use a hemodynamic monitor to try to titrate inotropes. I think that gives a more complete picture. So then I want to discuss the Himalaya trial with you. This was coordinated from Utrecht in the Netherlands by Professor Arjen Sloter, Professor Gabriel Rinkel, and Dr. Selina Gattier. I was also part of the investigators and also participated in this trial. There were two publications. The first was the pilot trial for the effect of induced hypertension on cerebral perfusion pressure in the late cerebral ischemia. And the second was the clinical outcomes study. But unfortunately, because of slow recruitment, the trial was stopped prematurely. So what did we do in the Himalaya trial? We aimed for preemptive informed consent. So we asked for informed consent on admission of the patient before the patient had DCI, so that we could randomize instantly as soon as signs of DCI would occur. So adult SAH patients were included with an aneurysm that was occluded because otherwise it was not safe to induce hypertension, we thought. And upon developing DCI, we randomized the patient to induced hypertension versus standard therapy, including a mean arterial pressure of more than 80 millimeters of mercury. DCI was defined as a GCS decrease of 1 point or more, or a new focal deficit, and excluding other causes for neurological deterioration, such as hydrocephalus. There were no other diagnostic criteria for DCI than clinical, and we used the Vergouwen criteria, but we did not use CT perfusion for the diagnosis or Doppler, for instance. So induced hypertension in those randomized for the intervention lasted for at least 24 to 48 hours, which and was done with norepinephrine at the ICU. So when the patient was not at the ICU, he was first transferred to the ICU. And we maintained the induced hypertension until neurological improvement, complications, or a MAP of 130, or a systole of up to 230, which we never reached in no patient, by the way. CT perfusion was done at DCI diagnosis, so before randomization and after 24 to 36 hours after randomization, and after the start of study treatment, that we called CTP2. So you see that in the intervention group, blood pressure was indeed higher. This was a pilot trial, so this was the first part of the study with 25 patients in total. And what you can see is that in the lowest perfused region, the CBF, as measured with the CT perfusion, was indeed higher in the intervention group, but it was borderline significant with a P of 0.05. And in the control group, there was no increase in the cerebral perfusion blood flow. So in the clinical part of the study, we aim to extend the number of inclusions, which we did not exceed. So in the end, we had 41 patients, and DCI to last for 1 hour. Spontaneous MAP of more than 120 was an inclusion criterion. Induced hypertension had to start within 3 hours after randomization, and when no improvement occurred within 24 hours after randomization, induced hypertension could be tapered. And so again, we had a successful induction of hypertension. There were more severe adverse events in the intervention group, borderline significant. So 57 versus 25% in the hypertension group. The serious adverse events were death in 6 versus 4 patients. Pneumothorax in 2 of the patients in the intervention group, atrial fibrillation, myocardial infarction, and 1 patient had multiple SAH severe adverse events. And then regarding the outcome of us, of course, this was an underpowered study of 41 patients, but we did not see any signal of benefit of induced hypertension in spite of the signal of an increased cerebral blood flow in the induced hypertension group. And this is interesting. So 18 patients showed clinical improvement within 24 hours. 12 and 57% in the hypertension group and 30% in the no hypertension group showed clinical improvement within 24 hours. And this was noted by the treating clinician. But 5 of these 12 patients with initial improvement had a poor outcome at 3 months, but 0 of the 6 patients with initial improvement in the control group had a poor outcome at 3 months. So this means that even when there's an initial clinical improvement, this does not seem to translate in long-term benefit. So this is why in the previous slide I said that I'm not convinced that when you see a patient improve upon induced hypertension, that will be a lasting effect. And this might be a hypothesis, it's not more than that, why norepinephrine might increase consciousness in patients. And that is because norepinephrine is known to be able to modulate wakefulness. So when you give norepinephrine and when you have a disturbed blood-brain barrier, you can imagine that norepinephrine may improve arousal in patients and not so much. And that may be a different effect from truly improving cerebral blood flow. But this is not a proven hypothesis. So finally, I want to point you to this very nice study where they looked at autoregulation limits. And to make a long story short, they found that patients that were below the lower border of the autoregulation limit in these SAH patients for a longer duration had a worse outcome. So when there was a longer time below the target lower border of autoregulation, you had a worse outcome signified by a higher 90 days modified ranking scale. So in conclusion, in the Netherlands, we apply induced hypertension optionally and according to all the guidelines, international guidelines, but also according to a current Dutch guideline. So a trial of induced hypertension can be undertaken in case of recent signs of DCI. You should weigh side effects and risks and feasibility and hold induced hypertension when there's no effect. But actually there's no proof how to apply induced hypertension, when, how, and in whom. So I cannot give good advice on that. So in my opinion, the way forward could be to do large multi-center randomized clinical trials for induced hypertension and DCI. We should have a better characterization of early DCI and possibly new diagnostic criteria, for instance, based on CT perfusion. And I think the way forward may be autoregulation guided blood pressure management in SAH patients, which can be used to treat DCI or be used as a prophylactic therapy. Thanks for your attention, and sorry to be a little bit over the 20 minutes.